Today's class is on retention and stability. Instability or relapse is orthodontics is mainly related to the changes of growth, maturation, and aging of the dentition and the occlusion, and changes related to inherent instability of the occlusion produced by orthodontic therapy. So coming to the definition of retention, Graeber defined retention as the holding of teeth in ideal aesthetic and functional position. Moyes defined it as retention in orthodontics is maintaining newly moved tooth in position long enough to aid in stabilizing their correction. So retention is necessary for reorganization of gingival and periodontal tissues after orthodontic tooth movement. The corrected tooth will be unstable after the treatment and due to constant soft tissue stretching. So you have to give sufficient time for the soft tissue to reorganize. And the pressure produced during the treatment will also have a relapse tendency for orthodontic treatment. And then hence the pressure tension of the either side of orthodontic tooth movement should be balanced in such a way that abnormal, excessive orthodontic tooth movement should not be produced. Thereby, we should not induce hyalinization of the bone. Changes produced by growth may also alter the orthodontic treatment. Schools of thoughts. So, retention schools of thoughts was there. The schools of thoughts of retentions are occlusal school of thoughts, mandibular incisor school of thoughts, apical base school of thought, and the musculature group of school of thoughts. The occlusal school of thought was given by Kingsley. It is stated as the occlusion of teeth is the most potent factor in determining the stability of teeth in their new position. That is, we should establish a maximum cuff to fossa relationship. The apical base of school of thoughts was given by Alex Lundstrom. The apical base was one of the most important factors in correction of malocclusion and maintenance of correct occlusion. That is, the relationship of dental structure over the apical base, either it is maxilla and mandible, should be properly established. That is, we need to maintain a proper intercanine width. The intercanine width per se, if it is 26 mm before treatment, after treatment also you have to maintain in such a way that it should not exceed plus or minus 2 mm. When you are going to alter the intercanine width, the stability of your treatment is a big question mark. And proper relationship of mandibular teeth into their apical basal bone should also be properly established. That is, excessive labial or lingual tipping should be avoided. Coming to the mandibular incisor school of thought, it was given by Grieve and Tweed, suggested that the mandibular incisor must be kept upright over the basal bone. Musculature school of thoughts is you have to balance a proper muscular balance. That is, your tongue musculature and the perioral musculature should be in a proper balance, by which you have to maintain the line of occlusion of your maxillary and mandibular arch after the treatment. Thereby, you enhance the stability of your orthodontic treatment. So, in orthodontic, retention phase is not a separate from treatment. It is a part of treatment itself and must be included in treatment planning. Riddle has grouped the retention planning after treatment, various orthodontic treatment, into 3 categories. Categories which requires no retention at all after treatment, and categories of orthodontic treatment where it requires a short-term retention, and certain orthodontic treatment requires a prolonged or permanent retention. So, Riddle has categorized in 3 groups. So, in case of correction of anterior crossbite, posterior crossbite, your antagonist teeth itself will act as an natural retentive measure and avoid the teeth to getting back to its normal position. Okay, so in that case, you need not worry about retention much. And in case of growth modification procedures, and in case of planned sequential extraction of your deciduous tooth to allow the eruption of your permanent teeth, all this is like orthodontic treatment in which the relapse will be very minimal. So retention will not be much required in these cases. And teeth which are moving to which are brought to a normal occlusion from their impacted position, that is, impacted canines will also be requiring no retention at all. Limited or short-term retention is required in class 1, class 2, division 1, division 2 cases treated by extractions, and in case of debite cases also. In class 1 non-extraction cases with proclination and spacing, and early correction of rotated teeth in which root formation has not completed. In these type of cases, limited or short-term retention is required. Permanent or semi-permanent retention is required mainly in spacing cases, in midline diastema. In case of midline diastema with high frenal attachment, you have to proceed with a minor surgical procedure like FRENECTOMY, followed by permanent retention by a fixed retainer type, because relapse tendency is much more in case of spacing. And in case of severe rotation cases, you need to proceed with supracrustal fibrotomy, and then you have to give a permanent retention for a longer period of time. The other cases that may require these type of permanent retention is arch expansion and class 2 division 2 debite cases, and the patient with abnormal musculature like tongue habits, you have to give a Holly with tongue grip as a reminder therapy so that relapse will be minimal. And in case of expansion in cleft palate patients, the fibrous band of soft tissue will collapse the arch again after treatment, after expanding your arch. So in that type of cases also, you will be needing a permanent retention. So Riddle has postulated 5 to 10 theorems regarding the retention. What are the theories of retention? We will see one by one. The first theorem is teeth that have been moved tend to return to their former position. This is that is, every reaction will have an equal and opposite reaction. Every action will have an equal and opposite reaction. Teeth that have been moved tend to return to their former position. So what should we do? What should we do? We have to establish a maximum intercuspation, give sufficient time for the musculature to adapt to the new position, and then reorganization of gingival and periodontal fibers has to be done. So you have to give a sufficient time. That phase is called as retention phase. Theorem 2 is elimination is the cause of the malocclusion. That is, we have to identify the etiology behind the malocclusion, identify it and eliminate it. Then you will have a stable treatment outcome. Theorem 3 is malocclusion should always be over-corrected as a safety factor. For example, in case of arch expansion, you expand the arch. You expand the arch in such a way that working cusp of your maxillary arch should come to buccal non-occlusion. So that means it has to touch your buccal cusp. You have to over-expand your maxillary arch, because there will be always 20% of relapse will be there in maxillary arch expansion. To compensate for that, we always over-expand. So malocclusion should always be over-corrected. And proper occlusion is a potent factor in holding the teeth in their corrected position. Occlusion should be at the maximum. Maximum intercuspation should be established, by which you can stabilize the occlusion, and this natural stabilization of occlusion after an orthodontic treatment will aid in retenting the tooth in the newly moved position. Theorem 5 is bone and adjacent tissue must be allowed sufficient time to reorganize. The rationale behind this is you use a retainer and after your active orthodontic tooth movement, and allow sufficient time for your soft tissues, your hard tissues around the teeth to reorganize in the newly moved position. Theorem 6 is your lower incision should be placed upright to the apical base. 90 to 100 degree should be maintained. It should be the IMP angle, and the interincisal angle should be maintained 125 degree, so that your stability will be at the maximum. Theorem 7 is correction carried out during period of growth are less likely to relapse than your serial extraction procedure, your headgear therapy, your face mask therapy. All will have a maximum effect and minimal relapse tendency. Theorem 8 is farther you move the teeth, less is the likelihood of relapse. The best example will be disinfection of your canines. Theorem 9 is arch form, particularly mandibular arch, cannot be altered permanently by an appliance therapy. What they mean is you should not alter your intercanine width and intermolar widths, not more than plus or minus 2 mm. Theorem 10 is many treated malocclusion require permanent retaining devices. That is your spacing cases and other severe rotated teeth and class 2 deep 2 cases will require permanent retaining devices, and you should not negotiate on that. When a treated case requires a permanent retention appliance, you have to explain to the patient and ask them to wear. Otherwise, your treatment will not be stable. But when you treat a case with meticulous occlusal goals and with respect to the dynamics of growth and occlusal function, surely you'll get an 100% good treatment outcome with a maximum stability. Then to summarize your theorems of occlusion, Theorem 1 is teeth that have been moved tend to return to their former position. Theorem 2 is eliminate the cause of malocclusion, will prevent the recurrence of relapse, and malocclusion should be always overcorrected as a safety factor. Proper occlusion is a potent factor in holding teeth in their corrected position. Bone and adjacent tissue must be allowed time to reorganize around the newly positioned teeth. Theorem 6 is if lower incisors are placed upright over the basal bone, they are more likely to remain in good alignment. Correction carried out. Theorem 7 is correction carried out during period of growth are less likely to relapse. And theorem 8 is the farther the tooth have been moved, the less is the likelihood of relapse. Theorem 9 is arch form, particularly mandibular arch form, cannot be altered permanently by an appliance therapy. And theorem 10 is many treated malocclusion require permanent retaining devices. Then with this note, moving on to the factors affecting the retention, stability is related to the force that act on the teeth, and hence it is the neuromuscular problem. There are countless factors that affect the stability. The stability of an orthodontic treatment is affected by the growth, arch dimension, incisor position, oral musculature, and the periodontal ligament traction, and the condition of your periodontal ligament fibers, the etiology of the malocclusion, and finally the functional occlusion that you establish after an orthodontic treatment. So there are various methods in aiding the retention. We can broadly classify them at natural means or mechanical procedures or by surgical procedures. So retention by natural means is moving the teeth into a position of stable static equilibrium where there exists in a state of minimal potential energy. For minimal potential, that is, you have to move a tooth to a stable static equilibrium where the harmony of your soft tissue and bone and readaptation of all your bone has to be achieved properly. That is, you have to give sufficient time for that to reorganize and correct root torque to ensure the root parallelism. And then you have to maintain the occlusal equilibrium and overcorrection of malocclusion wherever needed, and reshaping of incisor and restoration of the contacts has to be done. And for a proper retention to be established, Raleigh-Williams has established 6 keys of retention. The first key is incisal edge of lower incisor should be placed on the AP line 1 mm in front. So this creates an optimum balance. The second key is lower incisor apices should be spread distally to the crowns more than is generally considered appropriate, and the apices of lower lateral incisor must be spread more than those of the lateral incisors. When the lower incisor roots are left convergent or even parallel, the crowns tend to bunch up, and a fixed lower retainer is usually needed to prevent the post-treatment relapse. The third key is the apex of your lower cuspid should be positioned. Apex of your lower cuspid should be positioned distal to the crown. This is important in creating the post-treatment incisor stability because it reduces the tendency of the cuspid crown to tip forward into the incisor area. The fourth key is all the 4 incisor apices must be in the same labiolingual plane. The fifth key of retention is lower cuspid root apex must be positioned slightly buccal to the crown apex. The sixth key is lower incisor should be slenderized as needed, and you establish a maximum proximal contact so that relapse will be at the maximum. These are the 6 keys of retention given by Raleigh-Williams. Coming to the retainers, retainers are passive orthodontic appliances that help in maintaining and stabilizing the position of single tooth or teeth long enough to permit reorganization of supporting structures after the active phase of orthodontic therapy. Retainers can be simply classified as removable retainers and fixed retainers. So what is the ideal requirement of a retainer? Should restrain each tooth that has moved into the desired position. It should permit force to act freely on the retained teeth in a physiologic manner. It should be self-cleansing and it should be strong enough over required period of use, so that your stability of your orthodontic treatment can be achieved. So the types of retainers are removable and fixed retainer. Under removable retainer, you have your Holly retainer, wraparound or clip-on retainer, tooth position, Kessling's retainer, aesthetic maxer retainer, and beg retainer. In fixed retainers, you have your band and bonded type, direct bonded lingual retainer, simplified placement of bonded 3.3 retainers, and permanent lingual bonded retainers. Coming to Holly retainer, it is a traditional retainer with when the collars are snugly fitting the tooth, it is called as passive Holly retainer. The advantage is it is a widely used retainer. It has your labial bow and 2 adapts clasp and your acrylic component. These are the types of removable retainer. This is your beg retainer, this is your clip-on retainer, this is ASIC retainer with modification of replacement of missing tooth. So what is the advantage of removal retainer is it re-establish normal tissue when gingival hyperplasia is present, maintain occlusal relationship and interarch position ideally, is unlikely to break and can be modified according to the patient's requirement. Coming to the fixed bonded retainer, fixed retainers are generally used in condition where intra-arch stability is anticipated. It is completely invisible in the front, reduce the risk of caries, reduce the need for long-term patient cooperation, and it is both semi-permanent or even a permanent retention. So these are the various type of your fixed retainers. The purpose of bonded 3-3 retainer is to prevent the incisor recrowding, to achieve lower incisor position in space and keep the rotation center in incisor area, and it is ideal in case of these cases. They are grouped into first, second, and third generation retainers. Retainer is made up of Eligloy wire. This is your first generation 3-3 retainer. The second generation is 3-stranded wire. Distortion due to lack of rigidity, difficult to bend to optimal fit. The third generation is 0.032-inch stainless steel wire or gold-coated wire, which ends transfer to mechanical retention. This is a generation of your fixed retainers. Now, flexible spiral wire retainers are also available, which can be bonded from incisor to incisor, or from canine to canine, or from first premolar to premolar, depending upon the requirement of your patient needs. In case of gingival hyperplasia, we can make a V-bend like concept and we can bond the retainer also. So next is your direct bonded labial retainers. Direct bonded labial retainers are indicated in cases of space reopening in closed extraction sites in adults, that is in periodontally compromised patient. There will be labial retention can be done, compromising the aesthetics to maintain the occlusion. And a tendency of lingual crown collapse of canines that can be palatally impacted, and cases where there is a difficulty in holding the premolars, which were severely rotated premolars after derotation. If you feel like there will be tendency for relapse, then you can give a direct bonded labial retainers just to enhance stability. And then, in case of midline diastema, as we discussed earlier, like it needs a permanent retention. So even after you do a FRENECTOMY procedure, there is a relapse tendency is much more in case of diastema closure. So you'll be either using these techniques, bonding a fixed wire connecting 1-1 and 2-1. Otherwise, you can bond a attachment and tie it with a ligature wire. So this is ligature tie retention for a diastema closure case, and this is bonded retainer for midline diastema correction. What are the advantages of fixed retainers is it reduces need for patient cooperation. It is an alternate for conventional retainers. Bonded retainers are more aesthetic and minimal soft tissue irritation is there, and it does not affect speech as in case of removable retainer you have a bulkier acrylic portion and can be used for permanent or semi-permanent retention. So these are some of the surgical procedures that aids in retention. In case of high frenal attachment, we need to proceed with frenectomy procedure, and in case of derotation, you have to finish your treatment with a circumferential supracrustal fibrotomy to prevent the rotational relapse of your teeth. This is your frenectomy procedure. And then this is circumferential supracrustal fibrotomy, nothing but you will run the BP plate at an angulation of 45 degrees along your gingival sulcus. Thereby, you can approximate it to 2 to 3 mm below your alveolar crest to which the incision is extended. It is done during active tooth movement and gingival inflammation because of unpredictability of regeneration of epithelial attachment in these situations will be there. So the duration of retention can be either 3 to 6 months for full-time year of removal retainer, can be prolonged in case of diastema occlusion, and can be permanent in case of malocclusion where tooth movements are almost certain to be unstable. That is, example, the patient with an advanced periodontal diseases. Usually, we will advise the patient to wear the retainer 24/7 for the first 6 months after treatment, except for eating. This will be the ideal retention protocol that will be prescribed. So you have to know about the functional occlusion that you are going to establish after an orthodontic treatment. The pre-treatment occlusion is much more stable, and after you finish your orthodontic treatment, if the occlusion is not going to be functional, then your treatment is going to be a vain. The success of orthodontic treatment cannot be decided only with centric occlusion alone. You have to consider the centric relation. Centric relation is nothing but the most retrograde position contact of your condyle over your glenoid fossa. As per the study conducted with Brian in Sweden, he suggested that patient who exhibited multi-directional chewing, that is patient chewing right, left and protrusive, shows minimal migration of teeth. Patient showing bilateral chewing, there is a migration in bicuspid and cuspid region. Patient that were sagittal chewers, that is those who are easily protruding the jaws but locking them laterally, tend to show flare up of your upper incisor after the treatment. So you have to know about CR-CO discrepancy. Although ideally there should not be any discrepancy between your centric relation and centric occlusion. You can a maximum of 1 mm of discrepancy between your centric relation and centric occlusion is allowed after your treatment. Centric relation is nothing but your maximum retrograde position of your condyle on your glenoid fossa, and centric occlusion is the maximum intercuspation of your orthodontic treatment. So post-orthodontic treatment, there should not be much shift between your centric relation and centric occlusion. That is, your condyle should not have a much discrepancy in your glenoid fossa. Whereas orthodontic treatment modality may tend to shift the centric occlusion away from your centric relation, which is not stable. That may end up in TMD problem for that individual. You need to know this concept, that is the anterior component of occlusal force. The hinged joint of your mandible is posterior to the teeth, and the mandibular arc of closure has a direct mechanical influence on a dentition during function. The hinge closure action of your mandible results in a mechanical force between your opposing teeth that result in a mesial or anterior drift of the dentition, especially when then you appreciate a large CR-CO discrepancy exists. When teeth are not properly organized to a centric relation closure, the mandibular condyle must assume an eccentric position in the glenoid fossa that will cause a definite slide in your centric relation and centric occlusion. So you have to establish a post-orthodontic minimal centric relation and centric occlusal discrepancy for your treatment result to be more stable. The lower posterior teeth receives force to their distal inclines, leading to the mesial migration of these teeth, and subsequent crowding of the lower anterior teeth will form. The upper posterior teeth receive a force to their mesial incline which does not result in any anterior force serve one important function of stopping the hinge closure of mandible. And when anterior teeth have to stop mandible's closure, it is result in labial movement or splaying of the upper anterior teeth with deflective occlusions and deflective posterior teeth support. Okay, you understood. When you don't establish proper occlusion, the lower posterior teeth will receive a force in the inclines of mesial migration and produce a crowding of your lower anterior teeth. Upper posterior teeth receive a force to their mesial incline, which does not result in any anterior force, but serve one important function of stopping the hinge closure of your mandible. And when the anterior teeth have to stop mandible's closure, it will result in labial movement or splaying of your upper teeth with reflective occlusion in the dentition. So this is how your force, that is your lower posterior teeth receives a force from the distal inclines and leading to a mesial migration of your teeth. The upper posterior teeth receive a force to their mesial incline which does not result in anterior force. It serves an important factor in stopping the hinge closure of your mandible. So upper posterior teeth does not give any mesial force. Your lower mandibular molars give a mesial force. The upper maxillary force acts as a hinge to stop your anterior movement of your mandible. And when the anterior teeth have to stop the mandible's closure, it results in flaring and splaying anteriorly, result in a deflective occlusion. So, deflective occlusion and dentition, and there will be a lack of posterior support. When you don't establish a proper maximum intercuspation, this will happen. And there will be a discrepancy in your CR and CO, leading to an unstable occlusion and unstable treatment outcome, and that will lead to relapse. And significance of proper axial inclination. Physiological force can be applied from one tooth to another only when the vector is perpendicular to the common tangent, that is your lower mandibular incisor. Force should act this way to the upper incisor. This is called as a tangent of inflection. Only in this position, the torques that twist the incisor skeletal base are minimal, and hence you can enhance the stability of your treatment outcome. So mandibular canines are the key to stability in mandibular arch. If the bicanine with much cater after the treatment, it will tend to relapse. That is, you should not alter the intercanine width of mandible not more than plus or minus 2 mm. If canines position posteriorly, then there will be a minimal relapse or no relapse. Mandibular canines are well forward and widened laterally to accommodate the crowded lateral. There will be relapse. If you are going to push your canines back, that means if you are going to increase your intercanine width much, the relapse will be more. However, move the canine into the wider portion of your apical base, the stability will be more. Okay. So with that note, the stability is nothing but occlusal stabilization must. How will you calculate the stability? The occlusal stabilization must involve homeostasis. That is, the masticated system should be self-stabilizing after your orthodontic therapy. This was postulated by Moyes. The success index of orthodontic treatment or success index of your stability of your orthodontic treatment depends upon the magnitude of improvement divided by your magnitude of your relapse. Always relapse. How minimal it is will going to improve your orthodontic treatment outcome. Coming to your orthognathic surgery, it will be needing a long-term stability. So what are the concerns that you have to keep in muscle is stretching of the muscles of mastication and the suprahyoid musculature should be done minimal. Condylar distraction surgery will require long-term stability. Counterclockwise rotation of your mandible in case of ramal surgeries, we need a maximum retention. And rotational position changes between the proximal and distal segments will also need sufficient time for the muscles to readapt and the periosteum to readapt. And then these cases require long-term stability. So, how will you enhance the long-term stability following your orthodontic surgery is post-surgical therapy should involve upper and lower border wiring of mandible. Steinman pins to stabilize the maxilla has to be used, and skeletal wire fixation and rigid fixation is must. So with that note, today's class we have discussed about retention, schools of thoughts of retention, theories of retention, and how the classification given by Redel about no retention cases, minimal, moderate retention, and maximum retention cases, and types of retainers, the factors affecting retention of an orthodontic treatment, fixed retainers, removable retainers, and the stability of orthodontic treatment, importance of intercanine width and CRCO discrepancy, and long-term stability following an orthognathic surgery. So I conclude my today's class by saying, like, every orthodontist should think that retention is a continuation of treatment planning, and it requires the same kind of analytical thinking that is used to establish specific treatment objective at the beginning of the case. So retention is not a separate entity to deal it after treatment. Retention is an important entity that should be considered right from the day one of treatment planning, and it should be kept in mind due course of entire treatment. And finally, the retention should be properly implemented to enhance the stability of your orthodontic treatment. Thank you, students.